Good evening. Calling to order this meeting of the Board of New Health Corp. We have a quorum. Take the roll.
Yes.
We have a quorum. We are concerned about losing some members this evening, so I think we want to, before public comment, run through the votes. Meg?
If we can do a bulk consensus to approve 6-1 through 6-5 under the approval.
I make a motion to approve that, Megan.
Thank you, Dr. Pilati.
Second,
I'll second it.
Second,
all in favor?
Aye.
aye,
And are there any opposed? No opposition, any abstentions? Okay, motion carries unanimously. Thank you.
Okay, public comment?
Public comment.
Public comment. Mr. Harris? Is he here?
Yes.
Hello,
There you go. We can
how
hear you.
you doing? Yeah, I hear you. I'm just listening for now. I didn't have much to say. Thanks anyway.
Okay. Next.
By the way, we will be visiting Mr. Harris on Tuesday. Tomorrow at A. Holly Patterson.
Right.
Looking forward to seeing you.
Yes,
Mr. Ochoa Grosso.
Oh, yeah. Can you hear me all right?
Yes,
Paul, go ahead.
we can hear you, Paul.
All right. One question I have here before I go off on something else. Last finance meeting, we were looking into the finances from the LIF QHC. He was supposed to get back to us. Did he ever get back to you guys?
Some, but not all of what we asked for. We are continuing conversations with him.
All right. So how are we gonna, move forward with a relationship with this guy when he's, lying, cheating, stealing, how do you plan on getting that relationship to work?
Well, we are having ongoing conversations with the FQHCs, and we do have doctors from NUMC going over to them. So there has been some movement, and we'll continue to have that dialogue going forward.
Paul, just to follow up on what Mr. Donnelly said, I agree, building a relationship is going to be step by step. He has been welcoming of our physicians. We hope to increase referral volumes from the FQHC, and I think we take it from there. We have put all of our issues on the table at various meetings with him subsequent to that meeting, subsequent to that public meeting, and including CSEA's issues that we did highlight when we met with them.
All right.
We're up to my, Paul, that's it?
Yeah, I'm good for now. Thank you.
Okay, thank you. Okay, today's meeting, I think, is relatively exciting, but coming on the heels of some, concerning experiences. And when I say concerning, I mean globally, we are in the third wave of COVID, which is extremely unpleasant. We are seeing the volume at the hospital from the third wave of COVID, which is concerning. We are having some of, I think, what we term regulatory overreaction in response to that third wave, including a vaccine mandate that is very broad and draconian. We've been doing town halls. Dr. Booten and I met with the staff just Friday morning, in which we talked many unpleasant comments about the vaccine mandate. And we understand that certain people are opposed to it and that the mandate probably is aggressive, but it will make our lives in staffing our hospital and nursing home more difficult. But that having been said, we do have the beginnings of a plan coming together going forward, including some team members that we're bringing on. And primarily, we wanted to present to the board those elements of progress, which is what today's meeting is really about. I'm going to hand it over to Dr. Booten for his report, and then I think we will go straight into the presentations and questions from the board. So, Dr. Booten.
Good evening, everybody. Can everybody hear me?
Who would not dare to hear you?
Can you hear me?
Everybody can hear you.
Okay.
Yes,
All right.
thank you.
Since our last board meeting, we've been very busy here at NUMIC, and I'm going to go over a million of things. I'm going to try to be brief, but there's been a lot since we last met. We started working as a team on a narrative for the NIFA response. We know that we have 90 days, and I know Fried Maxick is going to take the lead on this. We've had an RFP for a short-term engagement for a turnaround specialist. I'll get over that. So prior to Fried Maxick coming on board, myself and the deputy CMOs met with all the division chiefs. We went over how to increase revenue, and we're looking for savings. Like I said, Fried Maxick actually won the RFP. They were the only company that actually had a public benefit corporation experience at Erie County and Westchester County Medical Center. We also,
Dr. Bhuthan, can you repeat what you just said, please?
yes, the company that's going to be presenting to you guys tonight, they won the RFP. They're the only ones that have a public benefit corporation experience, Erie County and Westchester County Medical Center. Got that?
Experience of what? Just
Working with companies that are hospitals that look like us.
Dr. Claudia, we're going to be presenting their bona fides in a minute as part of the
Okay.
presentation.
okay.
All right. Same thing with our special projects consultant that we brought on, Karen Blount Consulting. Again, she has Erie County Medical Center experience, downstate medical center experience, and she actually knows the building. We officially got the letter from American College of Surgeons that we're a bona fide level 1 trauma center certified.
Congratulations.
All right. We know that the Joint Commission will be here within the next 2 or 3 weeks. Our COVID numbers are going up, but it's worse in the South and in the Midwest. So therefore, all the resources that the Joint Commission has will be coming up to the Northeast. And so we need to be prepared for the Joint Commission. So we're getting prepared. I'll get through that. Our census today is 368. We're 50 patients over census, and 50 of those patients, 25 of them are COVID. Our average daily census, we're budgeted at 320. Today, we're at in the month of August, we were at 331. Our case mix index is again over budget. The census in the emergency department also has been picking up. We're like anybody else, we're overwhelmed in the emergency department. Our ambulatory surgeries are up. And again, at A. Holly Patterson, their census is through the roof. There are over 450. The new programs at A. Holly Patterson has already peaked at 35 patients, and we're early in the game over at A. Holly Patterson. Since our COVID census went up so much, we had to reopen the 18th floor. It's a pure 100% COVID patient floor. In terms of Joint Commission, we're having weekly department head meetings with Plan of Corrections. We're having senior leadership meetings. Executives are going down to the floors and actually practicing their scripting to work with the Joint Commission. Again, weekly rounds by department heads and chairperson, nursing department to look for stuff. We're doing a major SWOT analysis to look for stuff. In terms of like something that we can be proud of, our delinquency rate. One of the things that we're looking for at the Joint Commission, early in the year, it was 135%. As of last week, it was 15% delinquency rate. So we're moving in the right directions. Again, we're fixing all the stuff that we need to fix that the consultant had found when they did the consultant survey. In terms of the vaccine mandate, we're following New York State guidelines and the federal mandate. There's no religious exemptions. Again, you have to have a verification by a licensed practitioner to determine if the employee has specific pre-existing conditions. That's probably the only thing. There's a waiver form for any employee that needs to do this, and it's due by next Monday. On top of that, we have a small committee that's going to vet those employees that are applying for the waiver to see if if it actually meets merit. Our data so far, at A. Holly Patterson, the percentage is about 80% of our staff, about 114 staff members that still need to get the vaccine between now and the 27th. Here at the hospital, we're at 90% and moving forward. Each department is looking at their staff to see which one are not vaccinated and have potential backups for them. So we're working with each department to see where we fall short and how we can help them. Because the volume here at A. Holly Patterson has skyrocketed over the last several months, we're looking to ways where we can actually bolster the staff, whether it's augmenting the staff via agency or working behind the scenes with legal, HR, and finance to come up a way to come up with solutions and to incentivize the staff to do more. We're working on our 2022 budget. It's in process. We're asking for somewhere in the vicinity of a 10% reduction in savings. That's our goal for 2022 for now. Like I said, we have a new chairman. He's looking to increase employee engagement. He's had town halls, both at here and A. Holly Patterson. He's looking at community physicians. That's going to help us with the bottom line. He's looking at bringing in private groups, looking at physician navigators, a concierge service, and looking to increase the capacity of the operating room. We've had multiple meetings over the last month or so with multiple groups who are looking to do business here at Nassau University Medical Center. We've already hired a private family physician. We have a new plastic surgery group, private plastic surgery group that's going to be starting here. We've engaged with a private GYN group, which I'll dive into a little more. Again, neurology, urology, ENT, and even pulmonary critical care, looking to do business here with us at the hospital. When we sat down with the last OBGYN group, they were really frank with us. They want to do business here. They actually told us to take advantage of the fact that we're a safety net hospital and use that to our advantage. We're looking to open up an IPA, and that actually is going to produce a tremendous amount of groups that are unhappy at the Catholics, the Northwells, the Mount Sinai's, the NYU's, and they're going to be joining us. We're looking to do a joint venture with both an ambulatory surgery center and an infusion center. Again, using 340B as our platform. Again, we also met with a new vascular group last week that wants to do business with us at the hospital and at the nursing home. Again, our goal is to increase the capacity of the operating room, do a lot more elective C-sections, elective surgical cases, elective GYN cases, and do more deliveries here at the hospital, which means that we're going to need to renovate our NICU. We've already started to do the postpartum part of the hospital. We had a transformation grant and we started working on that. That's going to start October 1st. We're looking to do a specialty floor. Since we have the 8th floor, we're going to look to renovate it so that we can do a specialty floor for any of the private groups that are looking to come at the hospital. The priorities are really simple for us at this point. The quality of care is one of the most important things that we're going to need to do than anything else. I only have a couple more things to talk about. In terms of meeting with our consultants, we've had a few priorities that are low-lying fruits that we can actually jump on relatively quick. Things like building and coding that we know about, an observation unit. We're going to try to eliminate 1 to 2 day stays. We're going to try to decrease our readmission rate. Again, employee engagement and value-based purchasing. One of the major things that we wanted to talk about. Did you want to talk about the Joanne Group quickly?
No, let me, before I hand it off to Fried Maxick, let me just echo three things that Dr. Booten said. First of all, I want to commend the management team here, Dr. Booten, Janice, Shannon, for not being the type who will from their offices, but for really getting out on the units. I think it makes a huge difference to staff education, morale, and systems for them to do it from around the building and not from up here. I live in the Ivory Tower, but they actually get their rubber-soled shoes on and they get out there. One, two, when we sat with Dr. Riggs and discussed, when we sat with all the CMOs, actually discussed the need to really augment and expand our medical practices and find the right physicians who are accretive to our hospital, both mission and margin. Dr. Riggs ran with it, and I want to commend him. He's really had tremendous amount of traction, much more than I expected, and is really hitting the pavement hard. And the last piece is, life in a public benefit in a safety net hospital is always difficult. I think the last 18, 19 months have been extraordinarily challenging to our staff. I think they've held on tremendously well. And I think as a board, we should commend them. And I think that anything any and all of you can do to let them know that we appreciate the hard work, the dedication, the focus, and the extraordinary trying circumstances they work under would be appreciated. Now, turning to the main event for tonight, who am I handing it over to? Alan?
Ed, before you go, I just need to ask Dr. Booten and the team a question, because I know that we've had some staffing shortages and that's happening across the nation. So while I loved everything you said, and it looks like so many great things are happening, but are we going to be able to support it with what we've got? Or do you have a plan in place to be able to make sure that the people you partner with or collaborate with or bring on to the hospital, what's going to happen as far as maybe supporting them with staff and whatever else is needed?
So right now, nobody has staff. Nobody has staff. So we have to do with what we have.
Okay.
And we're going to try to look outside the box to figure out how we can actually increase staff within the building. And we're looking to agencies, we're looking elsewhere, but we do have resources here that we can work with. That's why I'm going to work with HR, I'm going to work with legal, I'm going to work with finance and nursing to figure out what we have in the building and how we can incentivize our staff to do more with what they have.
But Jen, let me also address it a little bit. So two things. First of all, I think I very much commend Dr. Booten in having serious vaccination rates that were impressive considering the nature of the rest of healthcare, and it's going to make a huge difference come the mandate that we are ahead of the curve and ahead of most other similarly.
I think they've done a tremendous job, Ed. I agree with you.
Right off the bat, I think on the vaccination front, we're going to have less attrition because of the mandate than most providers. I will say that both the hospital and AHP are doing better right now on that front than my business. So very much I commend Dr. Booten on that success. And the second thing is we are looking very closely at the HR process. If you go into John Donnelly's office right now, he has a gigantic flow chart that has all the steps to hire somebody at NUMIC, and he is hard at work trying to figure out how to streamline it. And he's been doing that for a couple of weeks, specifically in light of the issues that you highlighted.
And Jan and the rest of the board, we are having upcoming open houses, both at NUMC and A. Holly Patterson, to continue recruitment and be as aggressive as possible, knowing that it's a very, very competitive market.
Yeah, it's tough out there. It's tough out there. And I really appreciate all that you all are doing. And what Dr. Booten said, and I know that the whole team has been a part of that. It's fantastic. It's wonderful, wonderful news. So congratulations.
So one of the things that we're going to try to do is working with a new consultant, HR, and the union, because we're spending a ton of money on agency. We want to be able to use that fund for our own employees, but we have to do it in such a way that it actually makes sense. So I'd rather give the money to our employees as opposed to giving it to agencies. So.
I agree with that.
Okay, so let's talk about some of the projects we've been talking about here. Fried Maxick, guys, who am I handing this off to? Jack or Alan? Alan? It goes to you? Okay. Alan, introduce yourself, take our screen, and wow us.
Good afternoon, everybody, or good evening, I guess. Nice to meet you. If one of my colleagues, Steve Kishel, maybe if you can put the slide deck up on the screen, I'd appreciate it. But I'll just start with some general introductions. First of all, very pleased to meet with all of you. And it sounds like you've got a lot of really good things in flight at the hospital, and we're excited to be part of it. Joining me today are a few of my colleagues that'll be working on this engagement. Just kind of go around the horn and allow each of us to introduce ourselves. But my name is Al Gracie. I'm the practice leader for Fried Maxick. I lead the healthcare practice. I've been serving healthcare clients for over 30 years now. And probably over the past 20 years, have gotten to know public benefit corporations very, very well, most notably with Roswell Park Cancer Institute and Erie County Medical Center in the west side of the state, where we've done many, many different types of engagements related to financial and performance improvement, to compliance, to everything in between. Jack Sieber, maybe take a moment to introduce yourself. I'd appreciate it.
Thanks, Al. I have 20 years experience at Ernst & Young. I was a partner in their national performance improvement practice. Today we call transformation is really performance improvement and strategy. So that was our version of it back then. And we worked around the country helping health systems to improve their bottom lines and balance sheets. I spent 3 years at Excellus Blue Cross and Blue Shield. I was the senior vice president of network management for provider networks, worked with contracting with all the hospitals, physicians, and post-acute providers in upstate New York. For 5 years, I was the AVP of finance at Roswell Park Cancer Institute, which is one of the 4 public benefit corporations in New York State, owned by New York, has a lot of the same issues that you're dealing with here, including these big other post-employment benefit numbers that we all had to deal with. And I've been a director at Fried Maxick for about 10 years, very similar to the transformation practice that we built at E&Y. We built a similar capability here. We're active in partnerships with folks like Joe Tomeno and Grassi, and happy to be with everybody tonight.
Steve Kishel, I think you got the right slides up, so thank you. You want to take a minute and introduce yourself?
Okay, you're welcome. Yeah, hi, I'm Steve Kishel. I'm a principal in the healthcare consulting with Fried Maxick. I've been with the firm a little over 6 years. Prior to that, I spent 25 years with Kaleida Health. I served in several leadership roles. My last role was the patient experience officer. I was responsible for overall strategy, as well as improving the patient experience with Kaleida Health. I have significant experience in healthcare operations, both in consolidations as well as reductions in services. And I have a Master Black Belt in Lean Six Sigma methodologies. Nice to meet everyone today.
Thanks, Steve. Donna McKinney, you want to take a moment and introduce yourself?
Sure, I'm Donna McKinney. I'm a senior manager with Fried Maxick. I've got a little over 15 years of healthcare experience working at a large system up in Western New York, serving as vice president of hospital operations. Currently leading the revenue cycle practice for Fried Maxick, as well as heavily involved in the transformation practice as well, specializing in service line analysis and operational improvements.
Thanks, Donna. Lloyd Arkelian, can you take a moment, please?
Sorry about that. I had to unmute myself. This is Lloyd Arkelian. I have over 30 years experience, actually 40, but I stopped counting at 30. I didn't like the sound of anything over 30. But anyways, I've spent the last 12 years here at as a director at Fried Maxick, primarily heading up the revenue cycle and reimbursement regulatory areas. And then prior to Fried Maxick, had 15 years of service at Ernst & Young. Actually worked down in your market for about 3.5 years, worked there with all the hospitals down in that neck of the woods, both on the island as well as in Manhattan. So looking forward to working with everyone.
Thanks, Lloyd. And one aspect of our engagement that's a little unique is we are partnering with the Grassi firm, who we've gotten to know and work with for many years now, probably at least 10, probably going on 15 years. And Joe Tomeno, who's with us today, is the leader of their healthcare practice and is going to be very involved in this engagement. Joe, if you could take a moment to introduce yourself, I'd appreciate it.
Sure, thanks, Al. So I'm not a finance person here. I'm a nurse by background and also a CEO. So I've been a chief nursing officer in both acute care and long-term care. And I was chief executive officer of one of the divisions of Catholic Health Services on Long Island, ran all of their post-acute assets. I have about 10 years of experience in consulting, working with a variety of organizations. I think of most significance to you, I also, for 5 years, was on the board of Westchester Healthcare Corporation and was vice chair of the board that operates Westchester Medical Center. So went through many of the same struggles that you're doing, and certainly that will bring a perspective to this engagement. I'll be happy to work with my partners from Fried Maxick.
Thanks, Joe. Steve, if you could go to the next slide, please. And we're going to just give a little bit of high-level context on the Fried firm and the Grassi firm, and then we'll spend a couple of minutes going into some of our more relevant experiences. I know we have quite a bit of ground to cover, so we'll just try and touch on this lightly. But the Fried firm is over 60 years old. We're a top 100 firm in the country. We have over 300 personnel. As I mentioned earlier, I lead the healthcare practice, which has over 50 dedicated personnel to that practice. And we really serve many of the hospitals in the upstate geography, both from a consulting as well as a compliance perspective. Joe, if you can maybe talk about the Grassi firm for a moment, that would be appreciated. And Steve, if you can advance the slide. Thanks.
So, many of you know the Grassi name. We're a Long Island-based CPA firm. I lead our healthcare advisory practice, Grassi Healthcare Advisors. We work on healthcare transformation. We have access to a lot of data, the Trella Mosaic data that will be particularly beneficial for your initiatives. We also have worked on helping organizations develop innovative care delivery models, and particularly in behavioral health. We did a lot of work with New York City Health and Hospitals Corporation in this area. I'll be also bringing in two physicians onto my team, both of whom are under Delmont Medical Advisors. They are our minority and woman-owned business partner. Jackie Delmont, some of you may know, she's a very successful physician in the Freeport area. She knows your organization well. She also is CMO of ACO out here on Long Island, and also a large one in Manhattan. And also Amy Hoffman, Dr. Amy Hoffman, who's the head of psychiatry at Lincoln Hospital. So they'll be working with me on my team.
Thanks, Joe. Steve, can you advance the next slide, please? So collectively, our firms have a significant amount of experience with public benefit corporations. As we mentioned earlier, most of us on this call from our two firms have been working with PBCs for 10 plus years, some of us going on 30. But the takeaway here really is that our experience is not just longitudinally long, but we're also very deep. We've got involved in many different types of projects, ranging from revenue cycle to reimbursement enhancement, operations, supply chain, coding, et cetera. We've gotten to know some of the pecuniaries of being a public benefit corporation very well, insofar as the labor construct, state regulations, and some of the inherent challenges of being not only a public benefit corporation, but a safety net hospital as well. One of the things I think that's, a thing that we really are proud of is the value that we've delivered along the way. There are certain opportunities, if you will, that are available to public benefit corporations that Lloyd will talk about in a moment. But we've really striven to try and add value and pay for our own freight and then some during the course of our engagements. Lloyd, maybe if you could take a couple minutes to talk about some of the projects you've been involved on. I think that'd be helpful for the board and the participants here.
Sure, thanks, Al. So on some of the projects, two unique issues for an organization like yours, and I've worked with probably about 4 different public benefit corporations in my career, both here and at Ernst & Young. But yeah, one of the unique items of reimbursement opportunity is the intergovernmental transfer payment, which essentially is a methodology that helps compensate the safety net hospitals, the public hospitals, for the Medicaid losses and the uninsured losses that they're going to experience because Medicaid doesn't pay costs. They don't even, they don't pay anybody costs. So there's that aspect of it. And we work with, a couple hospitals here in Buffalo where we've dramatically increased their IGT payments, primarily due to recognizing that there's issues that there are disconnects between the way information gets reported in a Medicare cost report, which is the basis for the calculation, and as well as how Medicaid actually pays for services. So we've been pretty fortunate to basically help hospitals enhance that amount. The other way we enhance it is by looking at their operations. I've been involved in some situations where hospitals had a change in their Medicaid or their revenue cycle system and forgot to map certain information, and you just find that they didn't do a good job of mapping the information. So we basically helped them correct those situations. But that's an area where it's a significant revenue lever for a public benefit corporation. The other one is the similar type of reimbursement methodology for the nursing home for A. Holly Patterson. It's a different methodology. It's a little more straightforward methodology, but we've helped the hospital here in Buffalo optimize that revenue stream as well with some of the changes that they were experiencing. And with that, should I turn this over to Jack then?
Yes, please. Next slide too. Thanks.
Thanks. So the approach that we're going to be taking you through tonight is really kind of the same that we've used countless times in my experience, even across the country for many years. And there's 5 examples here that we're showing, and they range from, on the left-hand side, $2 billion systems that we've done transformational work, all the way to the right down to a little over $100 million. And the approach that we'll take you through is the same one that they used. And there's commonalities around some of the things that these providers have. One I would tell you is that New York State hospitals are typically kind of narrow margin, thin balance sheet kind of places, just because of the regulatory environment. They tend to be pretty lean already. So I know that working around the country, we go into other places and there'd be lots to find. There's lots of low hanging fruit. In New York, you got to work harder because a lot of the things that needed to be done have already been done, and it's trying to get that next level. Public entities, as we talked about a little earlier, are particularly challenging because they tend to have more challenging payer mixes. They may offer services that are for the community needs, but they tend to be kind of loss leaders, and they have extra layers of rules and complexity that you need to get through in order to get the results. One of the things I would say, and not only this example here, but really in all the clients we've worked at, the degree of improvement needed, how many $1 million do you need divided by what your total revenue base is? We've seen it go from a 3% improvement, 3% of your net revenue, all the way up to 23%. And those percentages have a lot to do with how deep you have to go and the kinds of solutions that you have to find. So that's one thing to think about. And the other thing I would say, we get questions a lot of times on, what is the difference between a transformation and a turnaround? And the real answer is they're really very similar. The things that you have to do in both can be very, very similar. The big difference, though, is time. And time is a function of cash. The more cash you have, the more time you have. And the more time you have, the more you can get into solutions, particularly that are growth related. One of the things that we find is amongst the solutions that happen, growth related solutions are the ones that they just take the longest to get to, right? Because especially in a market that's competitive and you're having to, really take market share that somebody else already has, it just takes time to get through that process. And we're going to get into this a little later when we talk about roles, but sometimes we found in my experience, it's actually easier to do places that are a turnaround than a transformation, because the organization is all on the same page and everybody gets that something has to happen. And we're going to talk about a little later, knowing that the organization needs to get these things done and having the sponsorship and support that you need at all levels is critical in order to make an implementation work. So we're going to show you some examples here of just some of the things that will happen in this assessment here that we're doing. The first thing we'll show is setting the business imperative. And the business imperative is just kind of a fancy name that we use to define, say, what's your target, right? And we want to be clear about what your target is right at the outset. And in the picture that we're showing you here, this is kind of a classic healthcare picture, and COVID has certainly wreaked havoc in everybody's picture here. But the blue line represents historical run rate, and run rate meaning it's the amount of income or loss from operations that you have. So when you strip out all the one-timers, right, and any relief that you're getting or grants or more lately COVID relief that we've been getting, and you get down to what is the operation actually creating. That sort of quality of earnings kind of thing is charted out. And there's typically a history that shows that over time, it's more and more difficult to keep that run rate up, and that, it kind of slides over time. The red line represents, so in this example, 2017 is we're walking in the door and we're saying, here's where we're at. The red line represents where you're going to be if you do nothing. And the green line represents the improvement that you're seeking to make, right? In this case, they had about 3 years, and you see there's about $50 million in this example. One of the things that is unique to healthcare is this concept that we call as negative arbitrage. And this is a healthcare thing. It's part of our business, and it basically means that the amount of increases that you get from the payers every year, when you add all the payers up together and what they're putting in for inflation, is typically not enough to cover your cost of living increases and your supply inflation. So every year, all healthcare entities that we have ever worked with have to overcome a number. And that's just to stay even with where you're at. And so for years, we go into these budget cycles where we're trying to figure out, how do I get this year's number? It could be 2, 3, 5 million, 6 million a year. Just to stay even, I got to find. So we've been on this perpetual performance improvement effort for years and years. And a lot of times by the time we show up, all of the ideas to get a 1-year hit to get me back up to where I was at, they're gone. You've done the things that you can do. And the reason why we call it transformation is we look out over multiple years and we put multiple years of arbitrage in there, and we say, what is the level of improvement that's needed? And the number is usually bigger than you typically see in a 1-year budget gap exercise. And it also requires you to think bigger and more creatively. That's why it's called transformation, because now we have to come up with ideas that we probably wouldn't have had to if the target wasn't so big. So it forces us to do bigger things and to really try to get us set up for long-term sustainability. The only thing I'll just say, and we're going to get into a little bit more of this when we talk about sponsorship, is when you're setting your business imperative, it's something that you want to communicate widely and deeply in the organization. It's that, along with the solution that we're going to show you in a second, is something that everybody needs to sort of get behind and rally behind. And the organization needs to sign up for getting that imperative number, not just the board. The board is always on board, The C-suite is typically on board, but when you start going down to the next layers, you get more and more resistance. So you want to try to really, if you're communicating and rallying behind this, we're talking about not so much the business imperative, but what life is going to be like afterwards, after we accomplish what needs to be done here, and we come out the other side in a much more long-term sustainable way. And the last thing I'll say is that, it's all right to stay on this page here. When you're doing implementations don't typically fail because the ideas were bad. They fail because the organization was not able to overcome the internal resistance to the ideas that were put forward to make that implementation happen. So it's that alignment of board, C-suite, and your department managers and so forth is critical to, no matter what the ideas are, to getting you to where you need to be. Okay, want to jump to the next page? So this page represents an example, like in the prior page, we needed to get $50 million. This was an example plan that another organization had. And the goal is to put together a plan that meets that business imperative. So there's a $50 million improvement that's put together. It's determined based upon the assessment, where are the places I'm going to go to get $50 million in this example, right? And you see there's really kind of three sections: growth, efficiency, and capital. And every plan I've ever done has all three aspects. There has to be some growth involved. You can't shrink your way to success. In this case, you see it's about a 30% growth, 70% efficiency, and then capital and cash is usually just trying to grow cash and to sustain cash flow. But as I said before, the amount of cash that you have determines how much time you have. We can't shrink our way to success, but I would also add, you can't grow your way out of where you are unless you have a lot of cash and a lot of time and the ability to invest in programs that will, bring more and more volume to you over time. And most places that are doing transformations or certainly turnarounds don't have the time that it would take to really do that and to steal market share. So at the end of the assessment, you'll have, here's our business imperative, here's the places that we believe that are there to get to that business imperative. And we're just going to take a minute and just kind of flash through some of the examples of the places in the assessment that we're looking at for you, so you get a sense of the kind of things that we'll be looking at.
Okay.
Go.
So this slide represents the growth opportunities we're going to be looking for, particularly in your service lines in both acute care and behavioral health. We're going to look at identifying unmet service needs in your catchment area, but more importantly, look at your capture of market share of these key service lines. I was glad to hear Dr. Booten talk about how great the census is doing, but we also want to look at what are those numbers contributing to the profitability of the organization. So if they're all, low case mix patients that are not terribly revenue generating, and if if you have system leakage of more optimal case mix patients, you could be supporting the profitability of your competitors, with taking on a lot of the low reimbursement cases while they're having the better ones. So for instance,
Joe, can you take a minute to talk about your experience at Westchester on this issue and the birth of the transplant program and how you grew that?
And the birth of which program?
The transplant program.
Oh, sure. So our focus at Westchester, we had actually the highest case mix in the country. We did not exist as a community hospital. We developed ourselves as a specialty hospital that received patients. We actually would help other hospitals develop their heart surgery programs. We didn't fight those programs because we wanted to do the heart transplants. So, the DRG on a heart transplant is like $500,000. At least back when I was on the board, it's probably even higher now. So now I'm not saying that's necessarily the strategy that you should take, because you're in a very different market than we were in Westchester. We were the only quaternary hospital between Albany and New York City. You have a very different competitive environment. But things I would look at here, Ed, are, you have a fairly qualified health center. We can actually drill down to the providers that are working there and see where are they sending their patients to end up getting kidney transplants or who need dialysis or heart surgery. Are they staying within your system, or are they being referred out to other places? And if we do a better job of capturing those opportunities, we're going to drive a much better revenue base and ultimately a better bottom line to your organization. Does that touch on what you wanted me to mention, Ed?
I mean, I specifically wanted to talk about how you were instrumental in building the transplant program, and it didn't exist when you got to Westchester. But just as far as the last point about drilling down in the data as far as referral volume, I want to make clear to everybody that's watching that you're not talking about data as reported by the FQHC. You're talking about claims data that you guys get from CMS.
Exactly. We get all the Medicare claims data. It's usually a quarter behind, and we can actually drill down. We won't be able to drill down by the FQHC, but we can get a list of all the providers that work there and look at where they're making their referrals to. Once we identify these areas where there can be growth and significant improvement, we can quantify a number to that. Now, there's some areas, for instance, you're the only trauma one in Nassau, you're only burn unit in Nassau. Those are going to be, loss leaders. We're not necessarily looking to show that they're financially productive. However, it creates a really good case for your organization to exist and to be able to get additional resources from the government. For instance, when we had trouble getting the governor to send us money to help support those programs, we literally sent him a closure plan. And then suddenly the money started flowing. So, those are areas that we'll be looking at where we can improve those. And also the reason why I added Dr. Hoffman on the team is I think a very important component of the role of a public benefit corporation is behavioral health. We want to look at opportunities there. I think, and to your point, Ed, about the transplant programs, I think particularly diabetes, renal disease, hypertension are issues where access to healthcare has put people at a significant deficit over time. And I think to develop a full suite of services that takes people from not just primary care and secondary care, but also the tertiary care, things like kidney transplant and heart transplant or supporting a heart transplant program, whatever is appropriate in your organization, to provide a full complement of care to that underserved population, and not just seeing yourself as kind of the safety net access point and then sending those people to other people for the higher level intensity. And then in the skilled nursing facility side, because of my expertise in operating them, I'm taking the lead on this, and we'll be looking at both opportunities for expense reduction, new revenue opportunities, and also making sure that your capital structure is appropriate. My partner from Freed Maxick is going to talk a little bit about how we're going to put some numbers to all these initiatives. Donna?
Thanks, Joe. So as Joe said, when you understand the service line stuff, understanding the revenue or the margin that comes along with it's going to be really important. So one of the things that we do is we understand the entire service line margin associated with it. So all those physician partnerships and those provider partnerships that Dr. Boughton, you talked about forming, really understanding what the downstream is that's coming as a result of them is going to be something that's critical from understanding your service line portion. A piece of that often is those investments you're making into those physicians. And so one of the things that Joe's going to be focusing on is going to be understanding what your comp model looks like, and are there any adjustments that need to be made to that from a physician or provider perspective. In addition to the service line information, revenue cycle is going to be something, as you guys already touched on, that's going to be an important area to be able to increase your revenue. So what we typically like to focus on when we do revenue cycle initiatives is the claim management process. So what does it look like from the time that a claim is generated through payment? Are you utilizing all the functionality in your system in order to automate your processes as much as possible? What is your denials opportunity and how is that being reported out? This is a critical piece because the transparency level in denials management is often something that a lot of organizations lack or don't have the level of in order to really drive down and understand root cause and what's causing those denials to happen, because they're often happening before they ever even hit the back office. We also look at the staffing associated with your revenue cycle, and then who's maintaining your system that you have, maintaining the revenue cycle systems that you have. In addition to that, Lloyd's going to talk about what we would do from a clinical documentation perspective and understanding where those opportunities are for that.
Yeah, and with the clinical documentation, we're typically looking for, you know, what kind of processes you have in place, what kind of safety net procedures do you have to make sure that the clinicians are documenting everything that they need to document to optimize your reimbursement, and not optimize, but I always like to think of it as being paid adequately for the services that you're providing. And oftentimes we see there's issues with not having the right skill sets within the organization, not having a system in place in order to do that. So we'll have a team of folks coming out to really, you know, look at it from a process perspective, a data perspective, and actually we'll probably review anywhere between 100 and 150 charts, so that it's not just going to be, well, we think there's a potential case mix increase. It's going to be, we're going to have specific charts that we will look at, that we'll select, and we'll be able to document where the opportunities are. And usually that leads us to what the systemic issues are within the organization, and then, you know, help us formulate a plan of what you need to do to go going forward. Steve, you flip to the reimbursement slide. So our reimbursement assessment is something we do on every transformation job, just like the revenue cycle section. With you, it's probably a little different is what we'll do with the intergovernmental transfer payment. And there, you know, the regulations are constantly changing in that area. And, you know, I had situations where, you know, things have changed between what the state wanted you to do, what the feds wanted you to do. You know, and one of my clients, we actually picked up $25 million because we took advantage of a situation where there was a disconnect between what the state wanted you to do and what the feds wanted you to do. And obviously they reap the benefits of that. But what we'll do is, for that area, we're going to focus on discrepancies that exist between the Medicare cost reporting and the Medicaid billing. You know, for example, I know you probably have a CPEP program down there. You know, CPEP is a bundle payment service where you bill for the Medicaid, you bill for the hospital and the physician at the same time, and you receive one payment. And what a lot of folks don't realize is that that Medicare cost report, which is the basis for doing the calculation, excludes all the physician costs. So we'll be looking at a fair number of those types of items to make sure there's proper alignment between revenue and expense, and that you're getting your fair share out of that program. We'll also look at operational issues that cause discrepancies in the reporting. You know, there's typically some issues there. The Medicare cost report, that's our traditional disproportionate share, indirect medical education, bad debts. You might have some allied health, but we'll look at all those issues to make sure that you're actually taking advantage of and properly reporting. And if you're not, the good news is we typically, if we find an issue, then we typically can go back to all the open cost reports. So it can go back, you know, 3-5 years, depending on where your open cost reports are. The same thing with the New York State cost report, both on the hospital side and the nursing home side. We'll have, you know, someone looking at those to make sure all the, you know, all the reimbursement settlement issues are handled correctly. And if they're not, we would, you know, make recommendations to, you know, actually go back. The look back period for the Medicaid is a little shorter than the Medicare portion, Medicare cost report. And the same thing with the intergovernmental transfer payment. You know, right now there's a 2019 that is being settled or should be filed shortly. And that's probably be the first one that we could actually look at. And with that, I'm going to turn this back over to Steve Kishel.
Sure. The next area that we're going to be looking at is we're going to be looking at your supply chain, pharmacy, and 340B opportunities. And ultimately, what we're going to do is going to be looking at the market basket to determine if there's opportunities for better product pricing and utilization. We will actually work with the physicians and identify the physician preference items and where there could be standardization along your cardiac and orthopedic. Pharmacy utilization, as well as a review of your purchase services and service contract opportunities. In addition to that, where our team will be looking at your 340B program to determine where there's opportunities to optimize the current program. Again, keeping in mind, we want to ensure that we drive the compliance as well as grow the program and negotiate favorable contract pharmacy and TPA deals. In addition to that, the next part, we're looking at labor and standards of care assessment. And the reason we put these together is because they really closely align. We're going to be using a multidisciplinary approach, and we'll conduct interviews as well as data analysis to get a better understanding of the processes from admissions to the relevant care transitions. And we'll identify opportunities to achieve a standard level of care. This will be done primarily with a focus on workflows, roles and responsibilities, and utilization of all resources. We'll use this information as well as we do the labor productivity and the benchmarking departments to peer hospitals. Again, those benchmarks are really directional. It's really understanding how you operationalize that, how we can drive improvements on the standard of care, length of stay, utilization, and utilizing those interviews and information gained in order to determine, what makes sense from a benchmark that's both achievable and aligned with your processes.
Steve, if I can just add something to the labor piece. What I would say is that we understand with a public benefit corporation that you may have some unique deals with the unions where there's some, we've had other public benefit corporation facilities where they've had some unique deals. So when we look at the benchmarks, we actually adjust if there's some nuances that you can't fix because of your agreements. Thanks.
Great point. Thank you, Lloyd.
And just to bring to a close the assessment section, I started to mention some of this stuff before where implementations don't fail because the ideas are bad. They can fail because of the inability to hold really all three levels that you see here accountable to own the target and do what it takes to get there. What we often see happen is that everyone agrees with the target and the need to hit that business imperative at the outset. But as you start to formulate your plan and you're seeing the details of the areas, that's where sometimes resistance can start to form, especially if it's in my area. And there's not usually a lot of controversy around growth because that's not painful, but if there are expense reduction areas, that's where sometimes you see the resistance starting to formulate. And you see the word substitution here a few times in the slide. And basically what we do here is everybody signs up for the business imperative and we're all working together at all three levels here to try to get that business imperative met and hit our target. So we're looking to hold our leaders accountable to participate in the process to determine where those initiatives are, which ones are the best, and to work to improve upon what those things are. And should there be a reason why we don't want to proceed with an initiative or it misses its target, the leader in that area is responsible to substitute something else to get the value of what that initiative is, because at the end of the day, the target never goes away. So as long as everybody's owning the target, then you'll get there. So I think that's it. And just, again, that's probably as much an implementation concept as it is an assessment thing. But having all three levels in sync is really critical. Steve, you want to take us through the plan for the assessment timing?
Sure. So our assessment phase typically is 8 weeks from data validation. So what we're going to really be focusing on right now is really the team organization and meeting cadences with all key folks in the process. We're going to be scheduling the kickoff meetings, leadership steering, as well as a data list will be distributed. We'll work closely with your leadership team. We'll identify those key owners. We'll distribute the data list and work to get that data as quickly as possible. And we'll validate any data or questions we have with the client. That's kind of the pre-work. Once we have the data validated in our office, typically what we see in many assessment is.
Steve, can I interject for a second?
Sure.
All right, so just speaking to the board, the executive team felt very strongly that Fried Maxick was the group to take us forward, but the way we're doing this from a contract perspective, and Meg can speak to this, is we're doing step one as a self-contained smaller contract data validation, gathering our assumptions, the dating Fried Maxick before we jump in with them to see that we are actually happy with their processes, engagement, thoughts, and of the like. Once we have more experience and we've been through some of these processes, we'll be coming to the board with a recommendation for a more full engagement. So I just wanted to talk about how Steve was talking about what's going to happen before we come back to the board for a full decision. The other thing is, Steve, if you could, I don't know if this is later in the presentation or if it's something that you guys cut earlier on, but if you could talk specifically about the business intelligence platform that you guys build and how you utilize that. It's later on. Okay, Steve, I'm sorry for that second comment. Go ahead.
No problem. We're going to address that later on in the presentation. But ultimately, what we're going to be working with is with you and your team is really to get to the data. Once we have the data, we're able to validate the data. We're going to be on site with your leadership and manager to understand current operations, very similar to what we shared earlier on in the assessment. From that information, we're going to develop a draft report and a prioritized draft report on the areas where we believe where you can achieve savings or revenue enhancement. And then we'll actually put together a finalized rapid assessment presentation to outline those ranges of opportunities for each area. Keep in mind this 8-week timeline is really contingent on us getting the data as quickly as possible, able to validate it. And again, I think you guys even brought up some of the key areas with regards to COVID. And one of the major influences will be what's going on within your organization with COVID-19 that may impact the engagement. But we'll work very closely with you with regards to communication and try to stay on once we have the data, the 8-week timeline. Anyone from our team like to add anything? Okay. Phase 2, and this is, I'm going to go through these slides rather quickly just to keep on target. Our phase 2 is really what to expect when moving to implementation. Jack, do you want to walk us through this first slide?
Yeah, thanks, Steve. So we're going through phase 2 just to do a flyby here to give you a sense of how this all fits together and how do you get to the result, right? Because nobody really wants to do an assessment. What you want is a result. But I think we're trying to show you when you take it all the way to the end, here's some of the discipline and some of the rigor that you're going to want to think about and that you're going to want to have, whether you do it yourself or, use somebody else, including us or anybody else you might think of. So, here is just the typical implementation. There's 10 steps to go from an idea to the results. The assessment gets you half the way there. It tells you where's the money, the high priority things, the value of them, and the realization schedule, because most of them have a ramp up, right? And the ramp ups are different time frames and so forth. And Steve's going to show you a couple of quick examples just to give you an idea of what happens when you're implementing those things. The detailed planning and all of that and getting right down to milestone measurement and things like that really happens in 6 through 10. So we know what the ideas are, but we're getting now granular about every step that has to happen in order to get to get us there. And Steve's going to take you through some of that, some of the discipline and rigor around that. And Edward, as you had mentioned, we also have a quick piece we're going to go through in a minute on business intelligence and how that supports the effort. Steve?
Okay, sure. Thank you, Jack. So as we move forward, one of the key things is ensuring that we're organizing for success. And we're going to have areas, as we shared in the earlier in the presentation, there are typically 7 to 8 areas, several areas for for improvement. One of the things that we see is really important with this transformation is there's a strong alignment to the board and the steering committee, as well as the leadership steering committee. Everything will funnel through the board and leadership steering committee with support of the transformation office. This really exhibit shows the different streams. We have 7 work streams that are really going to focus on service line management, revenue cycle, reimbursement, supply chain, 340B, HIM services, labor, and standard of care. And again, as we work through all of these, we'll also be aligning our business intelligence tools to be able to support each of these areas. As we move forward, each team will actually have an initiative documentation workbook, and you're going to hear this a lot throughout the implementation. We refer to it as the IDW. And typically the IDW cover page really kind of walks us through is what team is working on it, what's the initiative. So the first area could be a rev cycle team. We're going to focus on the bad debt reduction. It really identifies when realization is going to begin, when it ends, what the dollar amount, overall dollar amount, anything that's specific to any obstacles or roadmaps, we'll actually also have that defined on the IDW page. In addition to the IDW, as we move forward, the lower portion of the IDW really identifies, we're able to identify it at the entity level, cost center level, and the GL to be able to make sure that we can line it back to the financials, as well as Jack had shared earlier on in the conversation is, making sure we get buy-in and support. So each of those folks that are aligned to this initiative will be part of developing the IDW, as well as signing off that they agree to the opportunities in those areas. The next, each IDW actually has a work plan. In the work plan, we identify, working very closely with the operational lead, is what needs to happen, when are we going to start it, when are we going to end it, and we have the ability to track it to say if it's complete, if it's in progress, and we can track it at the progress level to make sure that they're achieving enough of the progress throughout the work plan to make sure that if the percentage isn't right, we're escalating that early on to assure that we can achieve the timeline. This is an example of our TMO tools that we utilize as well. So on a monthly basis, we can share with you how much have we completed, how many items are in the green and the moving forward.
I'm sorry.
What areas there.
Steve, if you could hold on.
Background.
Steve, if you could hold on for 1 second. Could everybody please mute their phones? We're getting a lot of interference. If you're not speaking, could you please mute your phones?
You can mute them.
Yes, can you mute everybody?
Okay, that's better. Thank you. So this slide actually shows each of the initiatives, and we're able to show it at a monthly level is, what have we been able to complete, what's on track, what's at risk, and what's overdue. And the idea is being able to have this and going in at the detail level and be able to show all the areas that we've been able to complete, what are those areas that are on time, but more importantly, what are at risk and what are the areas that we haven't been able to complete or are significantly overdue. We really like to focus at the at risk as well, because we don't want to see it get to the red. We want to be able to address it and move it to on target as quickly as possible. In addition to that, at each initiative level, we actually track the realization. So each team actually has, on a monthly basis, each initiative, what is that realization that expected? for each month. And we have the ability to track that to see, are we achieving it? Are we not achieving? What do we need to do to go back in and relook at that initiative to make sure that it's achieving its realization, full value. I'll move things to Jack
So
on the
as we-
business intelligence.
Yeah, so as we wrap up kind of this, what happens in implementation section, one of the areas that we plugged into our transformation implementations a long time ago was business intelligence. And the picture on the right here, I'll just tell you what it's trying to say. Essentially, we sometimes find that there's a critical shortcoming in the provider health systems that we have worked with on having timely information or accurate information or both. And so a lot of times we'll go in, we set up a data warehouse, we can dump information from any of your transaction systems, doesn't matter who the vendors are. We dump them into this data warehouse, and then we can together sort through and create reports in Tableau or whatever reporting software, if you guys have something, but it allows us to get to granular information about how are things going, not just on initiatives, right? So I might have 25 initiatives that I'm doing to get all of the money for you, but we're also looking at the base operation, right? What are volumes doing? How am I doing on my biweekly labor? Is everybody staying on budget? Some of those key business drivers, and business intelligence allows us to understand what's going on there if you don't have great reporting internally. So one of the things that we'll do on the assessment is start to understand where do you have good, solid information that you're getting to your managers so they know how things are going, and where do you have holes, and we'll try to build in the implementation data warehouse to fill those holes and see where things are going. And the reason that we do, beyond just looking at the initiatives that you have and how are those going, we also look at some of those other areas, volumes and so forth, because if the baseline business is going south while you're doing a great job on all your initiatives, your bottom line's still getting worse. So we have to keep an eye on both. The base business has to keep running. We still got to keep, things going while we're working on these initiatives. Both things together will bring you to an improvement of a bottom line to get you to what your target is.
Great. Thank you, Jack. Donna?
Thanks, Steve. So as Jack indicated, understanding where you guys are at with your different initiatives is going to be something that's really critical to overall success. And so one of the business intelligence tools that we'll be utilizing is it pertains to crediting. So you guys have identified a certain value on initiative, and now you're hitting that realization. Are you actually seeing the value coming through on your financials or not? And so these business intelligence dashboards are really important for helping you understand where are you at with those initiatives and what's on target and what's not on target yet, and what that variance is between them. This is something that we utilize not only for transformation with our clients, but it's also a really great budgeting tool that's utilized, just some understanding what's going on within your areas and your baseline businesses, Jack had indicated. Next slide, Steve. In addition, this is just another example of those tools that Jack was talking about. So here, for example, is the labor benchmarking tools that we roll out as part of our labor productivity. And so this really allows a higher level of transparency to not only the executive team, but also to your management team in terms of where they stand from a labor productivity perspective. And then what's causing those different variances that are out there. Allows you to be able to drill into this real time to understand if you have an overage from a RN perspective. Maybe it's an aid perspective. It could be that your FTEs are good, but your dollars are over because you don't have the right skill mix in place, or you're utilizing a lot of overtime. But these really allow you to be very interactive and drill down real time for folks to be able to identify root cause for their different initiatives.
Thank you, Donna.
Thank you.
Any questions?
Chairman, I will have a couple questions when you are done, and I'm not going to ask any question till you guys all ready, set.
Bobby, go ahead.
I think we're done.
Can you guys hear me?
Yeah.
Yes.
Okay, because I'm really messed up on my system today. Good evening, and Chairman, thank you for your leadership, doing such a great job. You know, I usually do not get impressed by when people provide a report. I have to admit, gentlemen, you did a good job. And not that easy for me to say this, but I do have a couple questions. With all your resume, is the echo coming through?
A little bit, yeah.
I don't know from where, but
We can hear you.
thank you, Chairman. Okay, it's a problem again. So what I'm saying is, Chairman, they had a excellent report. I think there's so many things I can compliment on. I hope all of our board members join to applaud the way they presented the report today. I have a question. I was driving that time when somebody said we can improve IGT, intergovernmental programs can do it better. I don't need to have an answer right now, but I can understand how you can do a better job than what is happening on that program, because at the end of the day, we cover that. Other things I have a question, you say revenue cycles. That's where our critical needs are on revenue cycles. Case mix, and that's another part we really need to be focused at. It's really important how we get reimbursed on our case mix. Chairman, I hope we're going to have review this their presentation, and it's very impressive. I'm glad that you took the initiatives to reach out and get the right firm. Yes, when people present, it's very rosy. My final question, I don't know which one gentleman going to, or the young lady going to answer it. You had done work in, you said 4, including the Nassau University Medical Center, public health corporations. I understand all your success. God bless you. I applaud you. Can you please tell me in 3 of the others where you failed or you was not able to succeed any program that you wanted to? It was due to because of the management of the hospital, or it was because of you overpromised something and you could not deliver it. That's very important to me. All the good things, we applaud you. You and I both knows the way you present the report to us is really great, and you know we need it. But can you be kind enough? Tell me your failure. I understand the success.
Bobby, can I answer 2 of your questions and hand the third back to them to answer?
Chairman, I don't want you to answer it. If you say we don't need the answer, then I'm not going to look for an answer.
No,
I'm going to leave in your hands.
I want to make 2 comments, and then I want to hand it back to the Freed Max team to answer your question. So as far as your revenue cycle, Bobby, you and I had 3 or 4 conversations about revenue cycle issues.
Yeah.
Relay
Yes.
all of your comments to these gentlemen, and they know that revenue cycle in our mind is top priority. And I relate all of your specific issues to them. So they are.
And I'm with you, Chairman.
They are aware of those issues. As far as the other piece, as far as going forward, part of the idea of the next couple of weeks is for us to develop benchmarks for success going forward and really trend sort of quarterly metrics so that we know that they're actually doing what they need to be doing, and so that we know that we're doing what we need to be doing. As far as the third question, and I thought it was a very sharp question, Freed Maxick team, when you failed, to tell us about your failures.
And again, I want to say thank you, Chairman, again, allowing me to have the question. We are a team. I stand with you and I support you 100%. And I want you to know, if you could have said, Bobby, we don't have a question, I would have accepted that too. I want you to know that.
No, I thought your first
I'm with you.
question, so.
Just, Jack, just if I might also, the first question you posed about IGT, I think is an excellent question. I'm going to ask Lloyd to help me a little bit with this, but so we've done a lot of work around IGT optimization, particularly Lloyd has, but one thing I think you're going to need to recognize, and I think you probably know this already, because IGT provides you relief in a different way than non-public entities, you essentially have to find, I'm going to make this up, $75 million of opportunity to get $60 million to the bottom line, for example, because there's an IGT offset for some of the improvements that you make because you're already getting reimbursed on a cost basis. And Lloyd, you can speak to this better than I can, but it's an advantage to you most of the time. But when we're doing improvements, you actually have to find more improvements to get a lower net number because of that benefit that you enjoy through IGT. Lloyd, can you talk a little bit about that? Because I think that is a nuance for these PBCs.
Yeah, so
But before you answer that question, Lloyd, I just want to add to the chairman's attention. You know, it is our money. We also spending money on behalf of the county, not what we send or spend and what we get back. We lose the money on that. So when you answering it, please be kind enough. If you answer it a little slow so I can understand it, how you can improve it, and the chairman and the other board member can understand it. Thank you.
So
Sure.
Jack, just to highlight what Dr. Claudia was saying, so here in Nassau County, the hospital funds the county share of the IGT and then gets it back because the county doesn't fund it. But Dr. Claudia, what Jack was talking about is a lot of the metrics in the cost report drive the total IGT amount, and half of it is state funded. So if we drive the total number up, even though we're funding half more, the part that's state funded are still more net dollars for us.
yeah,
All right, then we don't need that answer. So Jack, Mr. Lloyd, we can avoid that answer. Since chairman already understand it, he's already on top of that. I'm good with it. We don't need the answer.
very good.
So to answer the question about where we had, I think the question was, where have you failed? Let me just say that, and hopefully it came across in this presentation, we're very
in each hospital, not only where you fail in each hospital related to that. That's what I'm asking.
Yeah, and I think they all have the same common denominator. So let me just state that the process is very data driven, and it's very collaborative with the management team. So we leverage data and go through a process to identify areas of opportunity. And as Jack mentioned earlier, there's a process of synthesizing those ideas and germinating them into really an action plan. And when action plans are developed and they start to become implemented, that's when obstacles can present. It can be manifest in things like we lost a physician in a key area, and so that plan is not going to realize along the same trajectory that we thought that it would, because that physician was a key referrer or was very highly productive, and we have to go out and recruit and replace that physician, and so that sets us back. We could have other challenges in labor. You can have a strike. That's not uncommon. We can have COVID. We can have a cyber attack. There's any number of different things that can occur. But absent the extraordinary, what typically happens is when we go through the plan and we start to put it in motion, there's inherent obstacles that maybe weren't present on the surface that have to be overcome. And then if management decides that obstacle is too significant a barrier and we can't get the money from that particular opportunity, then as Jack mentioned, we have to go find a substitution, find a different opportunity to go and replace the unachievable opportunity. So that is typically what transpires is not every single idea is going to be realized on the timeline and the expected value because of all these little moving parts. So it's literally a lot of elbow grease to keep working at it and working at it and working at it to make sure that these ultimately that the global target is realized. I don't know, Jack or Lloyd or Donna, if you'd like to add to that.
I would just add, I think his question was, you know, where would you fail? And I think the different.
That's correct.
I think the difference with what our approach is, you know, we don't over promise and under deliver, because one of the things we do is we work with the management team and the executive team basically to co-validate the opportunity. So it's not just us coming up with the opportunities to say, yeah, this is it. There's really a whole process that happens where each manager or the executive team approves the initiatives. And so by that, you're getting the buy-in from the leadership team.
Yeah, and I think this is Steve Kishel, just to add to that.
Mr. Allen given the exact answer. He talking about tomorrow. I'm asking him where last 3 organizations that you had represented, that you had a failure. COVID is today. COVID was just today. COVID was not about what he answered. I am asking where in those 3 organizations that you had felt the failure. That is a specific question. I did not like Alan's answer at all, because I don't think that was answer to my question. I understand you're not over promising. I understand things does happen. I am not questioning that what does happen. We are here one team. I'm asking from the behalf of the team, can you tell us in these 3 places what or where, if there any failure that happened that you thought it's not going to be, but it did happen? That's all we're asking. We're not asking anything else.
Gentlemen, I think what Dr. Claudi's asking for are specific examples from other PBCs you've worked with.
So this is Donna, not going into the specific organization, but one of the, and I wouldn't say it was a total failure, because we did achieve some of the realization that we were expecting to on the revenue cycle side. But we've worked with organizations where it can be a struggle to align both the revenue cycle teams and the operations teams in understanding where the opportunity and where the root cause of the opportunity comes from. So taking, for example, utilization review. So utilization review is not it's not a business office revenue cycle problem. It's an issue that starts from the beginning of when the patient is determined whether they're admitted or whether they're going to be in observation status. If you don't have the organization aligned to bring all of those folks into the room and really bring them together as a team to resolve it, that's one of the issues where you won't necessarily see the realization that you should have. And we have experienced that with some other organizations where if that alignment's not there, then that's something that you're not going to achieve that full value.
I would just answer in addition to it.
That I have, I'm going to leave it to the chairman's decision. And but definitely you guys did not given me the answer. It sounds like you saying that you have 100% success, no failure. But I leave it to the chairman. We will have, because I respect our other board members to make the other questions in case they have one.
Well, let me just take one more shot at it here. I think we're probably struggling a little bit with the word failure. What I would tell you is, from a transformation perspective, of the 3 PBCs, we did this at 1, Roswell Park, right? We've done lots of things at the 3 that you talked about, and reimbursement and whatever, but we have a lot of experience with them, including me having worked at 1. Here's what happens in these projects, and I started to say it before, but I've never done an implementation where every single thing went according to the plan, never. So that's just the nature of what you're doing. And if you get 80, 90% of what you're going to get, you know, that's what happens. But the question is, what do you do with that 10% that didn't work out? And the answer is, we keep working at it. We find substitutions, we bring other things in, but we make our target. Now, to me, the risk is not usually not getting to the target. The risk is that it took longer to get to the target for the reasons that Al talked about and Donna talked about. But we get to the target. We might have to bring in more initiatives, but we don't stop working until we get to the target. So if you call it a failure, I suppose that's okay then.
All right, Jack,
But implementations by themselves are
let
messy.
me rephrase the question. Chairman, if I allowed,
Sure, Bobby. And then after that, Eva has a question.
okay. I won't use the word failure. Let me use, were you successful? Whatever you did the presentation to the other three institutions, 100%, 90%, 70%, 60% on implementation or a success? What would you say your successful rate was to implement those? But I'm asking that you had presented to those institutions. And I want to assure you one thing. I was the former chairman of this organization. And I'm a very proud member like others. And you're going to be surprised what I'm going to say. Right now, we have the best chairman, including me. I maybe was not as good chairman as we have right now. And we are 100% behind him, supporting him, and we will succeed under his leadership. So please tell him where your success was not a success.
Bobby, can I jump in here? So first of all, thank you for the compliment. And second of all, Bobby, so one of the things we did in diligencing these gentlemen is that we spoke to the president at ECMC, Tom Quattrochi, quite a bit. So we do actually have a lot of background information on their projects at ECMC. If you want to give me a call in the office tomorrow, I could chat with you about it. Is that okay, Bobby?
Yes, Chairman, that's pretty good enough. And you know, I'm with you and I'm 100% right behind you. And that's the way it is.
Okay, I'm going to be at Holly Patterson in the morning, but let's you and I touch base in the afternoon, okay? Excellent.
Eva.
Yeah, Eva.
Hi. So thank you for this presentation. I'm honing in on your comment that this is a data-driven decision, or rather process. I just want to share with you a flag that was raised in my mind. The prior consultants that came in and looked at this hospital and provided recommendations, Alvarez and Marcel, the report that we were given, there was some question about whether the conclusions were valid, because there was a question whether the data that they were driving those conclusions on or deriving those conclusions on were valid, particularly around, I think it was staffing as well as I think ER patients, if memory serves me correctly. So I just want to, I'm hesitant to go down another road with another set of consultants and end up with a report and recommendations that are then going to have the data by which these recommendations were made call into question. So I don't really have a question right now. I just wanted to voice that concern before we go too far down this road.
I think it's a good question. We did try to address it earlier in the presentation, and maybe it didn't come across as strongly as it should. But in the pre-assessment phase, which is where we're at now, when we make data requests, we go through an iterative process with management to verify that we have the correct data, it's in the right format, and they agree 100% that what we asked for is what we got. We take time to step them through what we're trying to do with the data, so there's alignment on what it's going to be used for and so forth. So I don't know the circumstances with Alvarez, if they went through such a process or if they just made a request and didn't come back and verify it. I don't know. I wasn't part of that, but I can tell you that our process is to verify it, because what we don't want to do is get down the road and have us being in a different place and with management because they thought we were using the data for a different purpose, or they didn't understand what data we needed and we didn't get a complete or accurate rendition of it.
And I very much appreciate that response. And I apologize if I missed that detail as you were conducting your presentation. And I'm raising it as a concern because the consequence of those conclusions being called into question is that many just decided to, discard the report entirely. And we certainly don't want to have a repeat of that occasion.
Yeah, Eva, I would say in addition to that, one of the things that we do is once we get that data, there's a lot of dialogue that occurs with the management team regarding what the data is telling us and if that's accurate or not, or what it means to really understand if we have the right data and if we need to go back and repull. So a lot of that is understanding not only what the data is saying, but what is the management team saying about the data, or how are they operationalizing their area that might make the data not reflect what is truly happening from a benchmark perspective. And so we may have to retool things from there, but it's there. In addition to that data and the data validation, there's a lot of conversations with management regarding how is the operations being done? How are you operationalizing things to help us understand the context of what the data means?
Great, thank you so much.
Chairman, this is Jan.
Jan, go ahead.
I just want to say thank you very much to the team and to the leadership for all the work that they put into identify Fried Maxick. But my question actually is, my comment is actually between what Bobby has asked and what Eva has stated, is that I'm very happy that Donna, I think McKinney, actually said that any data that they are viewing is vetted and gone over with the team, because my whole thing here is how can we make sure that the work they do turns out to be successful, and what challenges have they necessarily had in the past with other hospitals where we and UMC can avoid that and work as collaboratively as we can with the team to make sure that we get the answers that we really need in order for the hospital to become the best it can be.
Jan, I'm going to take that as an excellent segue into the next piece of the presentation. So one of the things that Fried Maxick admonished all of us is that they need boots on the ground, both for implementation and data collecting. If you saw in their report, they referred to it as a CTO, but they wanted a seasoned person who isn't part of day-to-day operations, meaning they didn't want to be taxing Dr. Booten or John or Meg or Rich Rank with what they were doing. They wanted somebody embedded in the organization to collect data, to collect the intangibles, and to help implement. And we did hire somebody after some extensive searching, and I'd like to introduce her, Karen Blunt, who is going to be telling us her bona fides and her findings thus far, and what she does and why she is.
Great, thank you. And I will be
You want to
brief.
speak up a little bit.
I will be brief because the hour is late. I'm a pediatric nurse practitioner by background. I have 40 years in healthcare. Was president of Women and Children's Hospital in Buffalo, was a chief nursing officer at St. Christopher's Hospital in Philadelphia, was a senior executive at Blue Cross and Blue Shield of Western New York, where I was responsible for everything to do with the MLR. And about 6 years ago, I started my consulting practice. I worked with Erie County Medical Center for about 5 years. I did a lot with Medicaid Redesigned District with them. Got Pathways to Excellence, which is a nursing designation for them. Worked a lot with behavioral health there and improving quality metrics. I did a turnaround at Downstate University Medical Center for about a year. Have worked at Hackensack University Medical Center, which is obviously a large academic medical center, improving length of stay and reducing readmissions. So I have quite a bit of experience working with safety nets, both as a consultant and an operator. And also have been at NUMIC previously. I was here about a year and a half ago for 3 years. I was brought in to help with CREPS, which is the Care Restructuring Enhancement Program. It was really an outgrowth of DSRIP. It came to the original 3 public benefit corporations and then expanded to 6. Numic was about a year and a half into CREPS and was actually at risk of losing all of the money and having it taken back by Medicare because you weren't hitting, the organization wasn't hitting the deliverables for the program. So I was brought in because I had implemented the program from day one at Erie County Medical Center successfully. They got perfect scores on every single report. So your former CFO asked that I come in and take a look at it. Within a month, we worked with the Department of Health to give Numic a second chance, basically. And from then on, Numic achieved perfect scores and maximized all of the reimbursement that you were entitled to from the program. So I got to know the team here and a lot of the challenges. I have been on site now 3 weeks. And have spoken with a number of key stakeholders, from physicians to department heads to executives, and would like to say that I'm really confident in talking with the team that the transformation can be achieved, and that there's a lot of enthusiasm and dedication, as I know a number of the board members have said, about being successful. So after the first 3 weeks, I have identified a number of areas that we're actually going to start working on. Want to just go to the next slide?
Yeah.
Oh, yep, sorry. So the first area is maximizing the Medicare VBP program. Numic in all 4 categories did leave dollars on the table. And that is around improving patient experience, hospital-acquired infections, morbidity and mortality in some areas. So that is an opportunity to begin to drill down and get some work teams going. Reducing the readmission rate on Numic is at 17.7%, and the average is 15.5%. And so again, we're going to be forming a work team to look at the admission process, identifying patients that are at high risk for readmission, and then putting programs in place to reduce that risk. There's a program just being rolled out by Health First for pay for performance metrics in the ambulatory clinics. There's actually $450,000 on the table for improving HEDIS metrics. Dr. Bryson and I are actually meeting with the Health First rep this week to hit the ground running on that program. HEDIS reported to me at Blue Cross and Blue Shield, so I have a lot of experience improving HEDIS metrics and really a pretty good understanding of that. The fourth has been mentioned, reducing denials. There's a significant amount of denials, primarily because there isn't a formal observation program here. I talked to Dr. Booten last week. We're actually, again, going to be forming an operational team to begin to look at that. That really has 2 positives to it. The first is obviously getting paid for patients that you're taking care of by leveling them appropriately. But also, these patients now are taking up beds in your acute inpatient setting. If we can take those patients out, put them in an appropriate setting, that can redeploy existing staff to bolster Janice's team with nurses that are existing, again, taking care of patients that should be in a different setting. The last is implementing the ambulatory CMS programs to maximize reimbursement. Over the past couple of years, there's been a lot of investment on the part of CMS to reimburse primary care practices to implement the bottom 2 programs, which is chronic care management and care transitions. CMS just increased the dollar amount for chronic care management in 2019, almost doubling it. So by putting in some care management programs and some proper documentation in the clinics, there's significant opportunity to get those dollars into the institution. And the first one, the annual wellness visit, what I found working with a number of organizations is in the Medicare annual wellness visit, providers tend to not list all of the appropriate comorbidities of patients. and that affects the weighting of those dollars. So that's usually a pretty easy fix. And obviously with Freed Maxic's help around data and data analysis, that's again an area of low-hanging fruit. So again, after 3 weeks, that's where we are. Certainly a lot more to do, as Freed Maxic has talked about a very detailed assessment. But in my experience, when you sort of got some traction as far as momentum in the organization, now's the time to strike while the iron's hot, get some of these programs in place so that when Freed comes in, we're building on a platform.
Thank you. So that's what's been going on around here the last couple of weeks. Plus dates.
Chairman, I want to applaud Jen and Eva to precisely ask that questions, especially let's make sure that these our consultants or whoever, whatever the title they're going to have, do not work from any of those garbage reports.
Bobby, I don't think that's what Eva was trying to say.
I would say that is a garbage report. I wanted, you know how I feel. That report should be investigated and people should be criminally charged. That's my opinion.
And I just want to go on record as saying those are not my words.
Yeah, but it's my words. It's my words. I want to know it's my words. I'm not afraid to say when it's come to the part of the hospitals. Best interest of the hospital always the first.
But
And,
Bobby, this is what I will say. I did have considerable conversations with the Alvarez team in the last couple of weeks. And I do think that they did not do a significant enough of a dive into the data. I think they had some conclusions they were driving at, and I think that they used a lot of benchmarks and heuristics, and they really didn't investigate the specifics at our hospital sufficiently. So I will agree with that.
Thank you very much, Chairman. I'm not going to, I just want to make sure they get the compliment. Even if they don't want it, that's perfectly fine. But they did precisely ask, and we should not work on behalf of that report. Thank you.
And again, data validity is our first goal in ideating next steps. Okay, so as mentioned, we will be back to the board to approve a more full engagement once we have more to show, but these projects are moving. Do we have anything else business-wise that we need to do today? Finance report, should we have Rich Rank send out a finance report, financial statements to everybody, or do we want to do a quick one next week? Is Warren's committee meeting?
Yes.
Okay, so we'll, okay. Okay. So Rich Rank will send financials out to everybody tomorrow. Warren has a finance committee coming up next week where they'll do a deeper dive. And I guess pending any other issues, we're ready to adjourn.
Chairman, I will make a motion to be adjourned if you don't mind.
Okay, motion, a second. I see a second. Ms. Pearson,
All in favor?
all in favor?
Aye.
All right.
And we are adjourned. Thank you all.